Well, welcome back to the Lunch and Learn. Today, if you're watching live, is Tuesday, October 14th. I have a dear friend and colleague with me, Dr. Jordan Shapiro, who is a board certified, actually, I guess you're triple board certified pediatrician, internal medicine doc, and gastroenterologist. Can you tell us about yourself and your practice? And we'll get into what makes people poop, which I'm super excited to talk about today.
Perfect. Yeah. So I'm so happy to be here. I'll start by saying it's hard to poop laying down, and I'm currently in the middle of getting a tattoo on an admin day. So, but yeah, so I have a practice called Gentle GI that's about a year old, and it's really focused on trauma-informed GI care. So the intersection of psychology and histories of trauma and gut issues and nutrition. So I see a lot of patients with histories of eating disorders or active eating disorders, Ehlers-Danlos syndrome, MCAS, and all kinds of things. But the goal is how to provide safe care and get people's guts better by getting to hear their stories.
Yes, and I long joke that I pretend to be a gastroenterologist because GI symptoms are so common in that triad of patients, both from the eating disorder standpoint, connective tissue standpoint, dysautonomia. So I spend a lot of time talking about guts, and so I'm really grateful you're here to add some clarity. So you and I talked about, just starting about talk about what is normal for us. Start
Yeah, I think I always like to go into things with just a sense of wonder. I think there's a quote, Plato or Socrates, that said, philosophy begins in wonder, well, or philosophy meaning love of knowledge. And so I think staying curious and just thinking that, like, in a normal setting, as soon as you chew food up and push it to the back of your throat and it hits the back of your throat, there's a nerve reflex that pushes it down into the food tube, your esophagus. And then from there until you feel the urge to poop in a normal setting, you don't have to do anything. So it goes down into the stomach. There's acid and other chemicals that, together with the grinding mechanical forces, like crush the food up and break it down. It's allowed through little bit by little bit into the small intestine, which is about 15 to 20 feet long in adults. And that's where the most of the absorption happens. Right as the food goes into the small intestine, the pancreas, which has two functions, like regulates your blood sugar with insulin, but it also makes most of the digestive enzymes in the body. It's pumping well coordinated amounts of digestive enzymes into the small bowel to meet with the food so that it can break it down and so we can absorb it. Um, lots of lots of things happen in the small intestine, from big nutrient like macronutrients like carbohydrates, fats, and proteins, to um, minerals and vitamins get absorbed at different parts. So it's so highly regulated and orchestrated. And then the gallbladder also dumps out a similar area to the pancreas, bile, to help break down fats so we can absorb those. After the breakdown products get to the end of the small intestine, they enter the large intestine, or the colon, and that's usually like 3.5 to 4 feet in adults. And when it gets to the end and it's pulled out some of the liquids, so it's a little bit more solid, that stretch of what fills the rectum, which is the very end of the colon, does two things. It relaxes part of the muscles at the bottom near our anus, the exit, so that when we feel the urge to go, we can go to the bathroom and just gently push and things come out. And it gives us the urge to go kind of simultaneously. And I'll talk more about what happens at the bottom, but there's a whole bunch of reflexes just even when you like eat and the stomach stretches a bit. There's a gastrocolic reflex where the nerves from the stomach to the colon say, hey, colon, there's more coming, start moving things along. So it's just a beautifully like regulated like nerves and hormones and other molecules that signal and message different parts of the bowel to do with specific functions.
I was muted there. So I love that you mentioned that, like, we don't have to think about this stuff. Our body is programmed with these mechanisms so that it just happens on our own. But due to a variety of reasons, both food behaviors and also other factors in our body, like connective tissue disorders, those things can go awry with time. So I know that many of us think about, although it's one giant tube from mouth to anus, there's things that we generally categorize as like upper GI function versus lower GI function. So today we're going to talk mostly about the the pooping mechanism. Where do you want to start there? Because it's all connected.
Yeah. I think just maybe highlighting a couple more specifics of how we poop. So at the bottom of the anus, there's two little like ring-like circle muscles that are stacked on top of each other. The internal anal sphincter is the one higher up, and the external anal sphincter. And so when the rectum stretches and that sends a message to our brain, hey, it's time to go, it actually, the internal anal sphincter, you have no control over. So thank God, because otherwise we would walk around and we would just constantly be pooping all over the place, and that would be a drag. So it's closed at baseline. When the rectum stretches and we get the urge to go, that one actually automatically relaxes. And the external anal sphincter below it is just like a biceps muscle. It's like it's a type of muscle called a skeletal muscle. So we actually have control over that. So we gently hold that with the internal anal sphincter automatically relaxed. We walk to the toilet or hole in the ground or however your motive of pooping is, and or location of pooping. And then we relax and gently increase the pressure in the abdomen by gently pushing, and things should slide out really nicely. I think that's really important because one, there are different types of constipation. A lot of people conceptualize it as, oh, my colon must be sluggish. And we definitely know in like the eating disorder world, where I think stepping back and looking at all GI issues, it's like 98% of patients have some sort of gut problem. So, but one of the most common ones is constipation. And traditional teaching is fix the eating disorder behavior in that population and everything will get better. And a lot of like the whole colon being a little sluggish, that's often the case. That will help, but not all the time. And there's one piece of the pooping mechanism that is the most likely to lag behind or not get better just with nourishment and eating disorder recovery. And that's actually the end that we just talked about.
Yep.
So
yeah, because as people are malnourished, your body is reserving energy for really important things like your heart beating and your kidneys making urine. And so having the muscles that move poop and liquids all the way downstream, those muscles get a little sluggish. And so I find that for the people that it's really purely just nourishment, when they start to eat in the first month, their symptoms are pretty, if not totally resolved, like quickly better. We know that answer pretty quickly. But for people who are like, yeah, I'm doing everything you're asking me to do, and still I'm really struggling, that's usually a clue early on that it's not just about nutrition itself. There's other mechanical factors and issues that can be going on. So I'll let you take it.
And there's a few things with those patients where the problem is really at the end, where parts of that history they'll disclose, and parts of it there's a lot of shame and embarrassment around. So the most common one is feeling a sense of incomplete evacuation. So I'll ask, like, when you go, do you feel like there's still some left in there? And some patients eventually can evacuate it if they go like repetitively multiple times over a period of half hour or so. But many still feel like there's something left in there. Patients very much do not want to advertise that they need to self-disimpact with a finger or an object to pull the stool out, or a splint in the vagina for female patients. And so, those types of things are actually really common, but we understand that it's embarrassing sometimes for patients, so they feel ashamed. And I will say, unfortunately, a lot of gastroenterologists don't think about pelvic floor issues. And there's a number of them. The one I described, the medical term for it is called dysynergic defecation. And I always just tell patients, just think about that normally well-coordinated pooping mechanics at the very bottom just got a little clumsy. And that can happen post-infection like COVID. That can happen after childbirth. It can happen from eating disorders. It can happen from Ehlers-Danlos. But the one other thing I would say is, if you feel like Goldilocks is the story of your anorectal area, and stool is either too hard and it's not enough laxatives, or the stool is liquidy, but there's never normal. And the last thing would be if patients say, even when it's soft or liquid, I still can't get it all out, that really tells me, or there's ribbon or pencil thin stools. That tells me very often, like almost all the time, that's going to be related to those muscles just being contracted when they should be relaxing when we're pushing to poop. And that's why it ends up coming out. And I think about it like pushing Play-Doh through those little things that you could put on the end of a Play-Doh tube and like push hair through like a little, I don't know if you ever played with those growing up.
Of course. Yeah, that's right. It's because it's a small hole and really soft stuff, so it squishes
Right.
through.
But I think it's important because a lot of patients will hear, they'll go to like Google, and like 50 years ago, we were like skinny stools equals like rectal cancer. And so like 9 out of 10 times, or probably more than that, that's not the, I mean, it's just because the muscles are tight, and treatment for that is not laxatives.
That's right. Yeah, making it softer is not going to fix the problem. So I know you and I send a ton of patients to pelvic floor physical therapy. I am having a pelvic floor physical therapist on this in the next couple of weeks who will talk about what that's really like. But I find that a lot of folks are hesitant to go to pelvic floor PT because they're worried that this is entirely going to involve an internal exam. They're worried that they're going to have another clinician have to do an exam. And while sometimes that can be very helpful in their diagnostic and therapeutic stuff, pelvic floor physical therapy is not an internal exam only. There's all kinds of things that deal with pelvic floor mechanics that you do not even have to get undressed for. So people can go in a trauma-informed way and see someone and get the care that they need without having to worry that it's going to be an invasive process. I just put a plug for.
Absolutely.
Yep.
Yeah, absolutely. And I think it's just good to know that they're capable of doing the full spectrum, including internal, but to have a conversation. And 1 out of 6 patients, when they're waiting to get into pelvic floor physical therapy, I'll recommend just a squatty potty. 1 out of 6 patients will get better just with that. And many of the others get partially better while they're waiting to get their first appointment. So there's a lot of things that don't involve internal work. And I think, the good pelvic floor physical therapists are all very trauma informed because they know that a lot of patients' issues down there, at least partly, are interwoven with histories of trauma, which we certainly don't want them getting re-traumatized.
Exactly. Yeah. And a squatty potty, for those folks who don't know, it's kind of like a step stool for your feet. It puts your feet higher up when you're sitting on a toilet so that your knees are higher up. And so it just changes the mechanics of your pelvic floor when you're pooping. Helps get things, literally makes you feel like you're squatting in a way.
Indeed.
Okay. So pelvic floor physical therapy. So understanding the mechanics, it's not just about like stool softeners. Pelvic floor physical therapy can be helpful from a mechanical standpoint. Can you just answer the very basic question? What is the normal frequency and how often people are pooping? Like what is
yeah. I mean, a lot of the clinical studies to get laxatives approved are based on like normal being about 3, what they refer to as complete. So not a sense of like something is left behind, spontaneous, meaning it's unassisted with medication, complete spontaneous bowel movement. So I tell patients, roughly 3. I think the difficulty is how much distress are you having in between them. So I definitely have patients who poop, every time they eat, or multiple times a day, and they still don't feel like they're emptying completely, and they're miserable. And then I have patients who poop like twice a week, but they're not hard, they're not straining, they're not painful, and they feel empty, and they're fine with it. And so it's a range, but I will usually use around 3, where they're not painful, you're not having to strain or sit excessive amounts of time, more than 3 to 5 minutes, and feel empty afterwards.
Sure. Yeah. So 3 times a week to 3 times a day is kind of the more or less the range that people will say. So this is a leading question. I'll say that. So for any woman who's wondering why their husband is in the bathroom for 45 minutes at a time, that's either a medical problem or perhaps a moment of peace and silence that they're going for. But most people should not be on the toilet for 45 minutes in order to.
Yeah. And and I think that, we talk about sleep hygiene, and I think bathroom hygiene, there's a recent study that came out that showed that hemorrhoids are more common in patients who bring their phone to the bathroom with them. And they're just sitting there killing time. So just the bedroom ideally is primarily for sleep, and I'll leave it at that for now.
That's fair.
Um, but I
So for
mean, the bathroom should primarily be for like sitting on the toilet for trying to go to the bathroom.
That's right. So for folks who have struggled with emptying their colon, their rectum,
Hmm.
they're feeling like, they have incomplete evacuation or they have hard stools or they're straining. What are some signs that they should absolutely seek care and not be
Yeah.
self-treating at home?
Yeah, I think anything that's getting progressively worse, patients who are like if they notice unexplained changes in weight, specifically weight loss, if there's blood in the stool,
Mhm.
it's never normal. It doesn't mean it's necessarily from something catastrophic, but and then I think pain is the other one where a lot of patients, and this becomes the layers of things that we have to unpack in a visit, but an anal fissure, many patients come in where they have this sharp pain. In the north, I used to say, does it feel like you poop a razor blade when you go to the bathroom, where there's like a sharp tear and blood? In the south, I've changed to asking, does it feel like you're pooping a cactus? Just
Mhm.
culture, but neither one being pleasant. But there's very few things in the anal area that hurt with that type of sharp pain. The reason that that's important is a lot of patients see blood and and a lot of doctors too, and think, oh, it's just hemorrhoids. And I think that with fissures, the important thing is you can't just slap like preparation H or steroid cream on it. You can't just take fiber that's part of it to soften the stool, but you actually need to use like compounded ointments that have a muscle relaxant and lidocaine so it doesn't hurt. And the reason for that is that can mimic pelvic floor dysfunction, even on some objective testing. There's a test called anorectal manometry where we put a catheter in the bottom and it has
Mhm.
pressure sensors to see if the muscles are like spastic and not relaxing normally when we try to poop. So when you have a tear, the muscle goes, it spasms, and then it's basically telling your body, please don't send more through here, it hurts. And the issue is that every time you poop, it tears, it spasms again, and it becomes
Mhm.
this feedback cycle where until you like use an ointment that makes it not hurt and relaxes the muscle, you can't get out of that. So I think those are kind of the main things that I would say. And the last thing I'd say, I mean, I think if it's gotten to the point where you're needing to disimpact yourself and use finger in those things, like that's important because in the studies comparing patients with like irritable bowel syndrome, diarrhea versus constipation, you think, well, with diarrhea, it's hard to go out to dinner. You've got to know where the bathrooms are. You don't want to have an incontinence episode or loss of stool. But overall quality of life was a lot worse in patients with constipation over and over again, just because they never get a sense of feeling empty. And so I think sometimes we're like, oh, it's just constipation. But I think the other important thing, because it's so common in patients with Ehlers-Danlos and MCAS and histories of eating disorders, is a lot of what you termed kind of upper symptoms like bloating, feeling full early, gas symptoms. We know now that because it's a tube,
Mhm.
that even if you look at our national AGA or American Gastroenterological Association guidelines for bloating, there's a ton of causes that it could be,
Mhm.
but it starts the algorithm with address and sort out the constipation piece if it's there. Because many times if you send someone to like a pelvic floor physical therapist, or you find the right cocktail of fiber and laxatives, and pelvic floor physical therapy, patients bloating and all the upper symptoms will get dramatically better or even all the way better. So we often segment the bowel like that and have done that historically. But in all of the medicine traditions that say, well, we just want to get to the root cause, I often will end visits by telling patients the cause is literally at the root of your GI tract,
Yep.
in that area. And I think until you fix that, a lot of the other stuff, whether you're treating SIBO or small intestinal overgrowth or other conditions that can happen higher up, you may temporarily make things better, but it's not going to have a long lasting effect if there's still ongoing pelvic floor dysfunction.
Yeah, absolutely. I mean, it makes sense to anyone. You don't need a medical degree. Like if if it's like pinching off a garden hose, if the tail end of this tube is not performing well, then everything upstream is going to get dysfunctional. So I agree with you. And just a side note in terms of urinary symptoms, bladder frequency, urgency, and incontinence, like still addressing the colon and the constipation is important because all of this stuff is tied quite literally, as you said, at the root. So
Yeah.
they're
And
not
it's,
separate. Yeah.
yeah, and it can happen in men too, like there's always the patients who have all the risk factors, like they had, vaginal deliveries and they had tears or episiotomies and sutures and or they had a hysterectomy or histories of trauma. But it can happen in men too. And I think in both, like in all humans, sometimes all the risk factors are there. In men it can be, post-radical prostatectomy or like pelvic radiation, but sometimes it just happens. And I think as common as this is, and you and I are very like sensitive and aware of this, I have patients who've been to 4 or 5 GI doctors in major medical centers, and nobody's ever talked about doing a rectal exam to assess the muscles or referring to a pelvic floor physical therapist. And so while it is a statistically speaking, like 25 to 50% of constipation has some component of like pelvic floor related drivers of the symptoms. In practice, it's a minority of doctors who actually pay attention to it. And so there's a huge disconnect there.
Yeah, I agree. Anything else that this population of patients would benefit from hearing today? I don't want to get into medication details specifically, but anything
Yeah,
else, pointers for folks?
I think a couple of things. I think one is, just to reiterate, a lot of the upper symptoms, if there's any component of lower like pelvic floor dysfunction, deal with it first and see what's left, because it's often not much after if that's addressed. I think the other thing is some of the feelings, like feeling full early, is just another loss of a common reflex where the stomach is supposed to accommodate and make room for food. So when we eat, the stomach expands and it makes room for incoming food, just like, it's called accommodations. I always tell patients, if you have accommodating family members and you're driving through their part of town, you need a place to stay, they're going to make room for you no matter what. That's how the stomach should work. But especially after, restrictive eating disorders, is probably the most common. Many patients feel like after 2 or 3 bites they're stuffed, and they often get labeled as gastroparesis and things like this, and that can happen too. But I think that I see more commonly where the stomach empties normally, but it's just that it doesn't receive food. And so all these symptoms, from upper stuff to constipation, the importance of addressing these is that many times especially in the eating disorder population, patients end up in jail where even when they're trying really hard to work on eating disorder recovery, the GI symptoms limit them from being able to eat. And eating consistently, like when the gut has had, some insults to it from a variety of things, when it's been through some things, like many of our patients have, it's so vulnerable to little changes in regularity. And so just stimulating those reflexes and thinking, if you don't use it, you lose it. And many times patients do their best on their own, and it's just too much. And so I think that's where seeing, an eating disorder focused, internist or primary care doctor or a GI doctor who understands these things can help with medications and other therapies to treat the symptoms to support recovery. Because ultimately that is the thing that is going to literally save your life. That is the thing that is literally going to give you your quality of life back. And as much as all of us would love to avoid medications, at times I tell patients, I want to be really aggressive because you worked your ass off to get better. And this is keeping you or this is putting you at risk of sliding backwards.
That's exactly right. Yeah, that's exactly right. Awesome. Jordan, can you tell folks where they can find you and which states you're licensed in?
Yes. So currently licensed in Texas and Colorado and soon to be Georgia. I am if you look at the gentlegi.com, that takes you to our website where you can see some information about the practice and schedule or reach out to us. And then on Instagram, just Jordan Shapiro, MD. And always happy to pretty well connected. So sometimes I feel like I'm a big switchboard for people who are looking for connections to providers who they can see in their area if they're unable to see me. So I'm always happy to help.
Awesome. Thanks so much for your information today. I really appreciate it.
Yeah, thanks for having me.